without further ado, I think we'll go to our clinical panel. A lot of questions were submitted online. So joining the clinical panel are some of the members you've already met. So Dr. Tobin, Dr. Appleberry, and Bishan Singh from the ADLD Center. I have a few additional guests I will introduce now. So Dr. Litsa Gavrilova is also going to join us. She's an expert in clinical genomics and neurology, whose research areas of interest are in the fields of mitochondrial medicine and neurogenetics. Dr. Gavrilova studies mitochondrial myopathy, multisystemic mitochondrial disorders, Friedreich's ataxia, among other mitochondrial disorders. And her research goal is to improve understanding of mitochondrial dysfunction and disease. So welcome, Dr. Gavrilova. Then we have Erin Logley. Erin is our genetic counselor in neurology, and she specializes in both adult and pediatric neurogenetic disorders. She received her master's degree in genetic counseling through the University of Nebraska Medical Center, where she worked previously as a pediatric genetic counselor before she transitioned to Mayo Clinic in 2023. So welcome, Erin. Then we have a couple clinical folks online. I'll introduce both of them. Dr. Karthik Muthusamy is a neurogeneticist at Mayo Clinic, Florida campus. He's a clinician with a background in neurology and clinical genomics and with practice that focuses on complex inherited neurologic disorders. His research interests include adult onset leukodystrophies, congenital disorders of glycosylation, and neurofibromatosis. So welcome, Dr. Muthusamy. And then last but not the least is Dr. Sasha Gupta. Dr. Gupta is an assistant professor of neurology. After completing a BA in neurobiology from UC Berkeley and MD from Yale, she did her neurology residency at UCSF, followed by a neuroimmunology fellowship. She's currently studying CAR T-cell therapy in autoimmune and infectious diseases. So thank you all for being here. So we had some questions submitted online when people were registering. So I will maybe start with those questions as more questions kind of come in. So a lot of this has been covered. So I'll just kind of go through what has been covered. And then if any of you want to add to that, please do. Perhaps could you add some of these are patient questions. So do you think lack of thirst and lack of appetite could be related to ADLD autonomic dysfunction? And if so, are there any specific strategies to manage them? Dr. Gavrilova, you want to take that?
Can you hear me? Part of the autonomic symptoms that are more classically associated with neurological conditions, including ADLD, I'll just be perhaps more simple in explaining what autonomic dysfunction is. Basically, these are subconscious functions of our body. We don't quite think about how our heart works or when we sweat or how our gut moves. So these are examples of autonomic function. Specifically, thirst or appetite are things that are not classically recognized as a part of this autonomic symptom. They're regulated by different parts of the brain, should I say. So the simple answer is we so far have not recognized thirst or appetite as part of these autonomic symptoms.
Okay, thank you. Moving on, I have a question for you, Erin. The question is, I would like to know about how to test a newborn baby for ADLD. And so maybe, do you want to comment on pre-implantation genetics and go take it on? Yeah.
I think. Sorry. Oh. There you go.
Okay, thank you. Thanks for the question. So when we think about individuals with a genetic condition, they might be interested in family planning and might be worried or apprehensive about passing a genetic condition on to their offspring or future generations. So now what we can do as part of the in vitro fertilization process in the creation of embryos is take a small sample of the cells of the embryo and perform pre-implantation genetic testing on them. And that would allow us to determine which embryos are at risk of harboring that genetic variant and which ones are at lower risk. And then for the embryos that are thought to be at lower risk of the genetic condition, they can be implanted to start the pregnancy. So a way of providing patients and families with more actionability in reducing that risk of passing it on.
Thank you. So just to clarify, this is not part of newborn screening? Yeah, okay. Question for maybe Dr. Tobin. Again, it gets into more specifically about management, but is there any specific management for urinary incontinence in patients with ADLD?
Yeah, so the urinary incontinence is a couple of different strategies for how to manage that. And so the first thing is to avoid bladder irritants. So common bladder irritants, you'd think about alcohol and caffeine. Other ones that you mightn't think about, grapefruit juice, vitamin C, and carbonated beverages. So the bubbles themselves, not just the caffeine in the soda, can cause bladder irritation. So reducing those is first line. And then the next thing to do then, if there's still urgency or incontinence, there is to do a bladder scan, so an ultrasound of the bladder to see if you're retaining urine. So if there's a high post-void residual, so if there's urine still in the bladder after urinating, then it's usually recommended to do intermittent self-catheterization. And if there isn't a high post-void residual, then you can use medications. And we usually recommend using a non-sedating medication such as trospium. There's other ones such as oxybutynin, which can be used as well. After that, there's kind of more so invasive therapies. So for people who are having a lot of bladder contractions, not responsive to medications, you can use Botox into the bladder itself. And then there's some studies, there's short-term studies of tibial nerve stimulation where you do external tibial nerve stimulation, which has been shown to improve urgency symptoms over a kind of a 6-week period, but there hasn't been long-term studies on that. And then there's also bladder stimulators, which are actually nerve root stimulators. They're stimulated at the S3 nerve root. And there's uncontrolled studies of that as a high rate of revision of the stimulator itself. And then for people who are having and this is very rare, but you can do continent urinary diversion, where you can basically it's like a stoma but for the bladder. So you can divert the urine out onto the abdominal wall. But it's very rare that we need to do those type of procedures.
Thank you. I think there's a follow-up question to that, so maybe I'll let you answer, somewhat related maybe. How do you suggest managing patients with both urinary retention and high anal tone resulting in severe constipation?
So the constipation typically isn't caused so much by high anal tone, but the high anal tone may be a consequence of the constipation. So the urinary dysfunction itself is actually made worse by the constipation. So the first thing to treat there is the constipation, the slow transit, and essentially to titrate laxatives to try to achieve a single fully formed bowel motion per day. Then once that's done, then basically go down the same algorithm for managing the urinary dysfunction.
Thank you. I'll maybe take this question to Dr. Muthusamy online. So the list of sites in the clinical care network has 5 sites in the US. Is there a strategy to begin identifying new diagnoses more broadly in the US, or is it too early because the understanding of LMNB ADLD is still new and underappreciated? Are clusters of ADLD present within some areas of the US, or it does appear this way because the programs are now focused on this condition? So I guess the question, yeah, did you get it, Dr. Muthusamy? Yeah.
Yeah, kind of.
Okay.
As many talks have pointed out, I think it's still kind of underdiagnosed. So I don't think even now, most of the patients referred to us from our autoimmune neurology colleagues have had the diagnosis of MS. They've lived with it for more than a couple of years. So I think it's hard to say unless we start diagnosing more. So I do think the first step is to increase awareness among physicians about this rare condition. So it might not be as rare as Dr. Pandit pointed out. Like CSF1R, when it was supposed to be very rare, but now it might be the most common adult onset leukodystrophy at this time. So I think increasing awareness would be the first step, but once they're diagnosed, then they could be referred to specialized centers. I'm not sure if that answered all the question completely.
Yeah, I think that's helpful. Thank you.
So I think in terms of the clusters, I think there are clusters, and that's so in terms of clustering of patients, I think there are clusters, and that those clusters are more because, like we said, there are very large families which have ADLD, and if they are clustered around a geographic location, that kind of accounts for that, and potentially they will go and see the same physician. And I think so. An example of that is there's a very large French Canadian group family, which was reported in the literature a few years ago, and I think the Swedish family is also a good example of that. So I think the clusters really come from the fact that you have large families with the disease.
Good to know. Thank you.
But I do have still contact. I'm originally from India, so I do have a lot of families with this clinical diagnosis based on imaging and the overall clinical manifestations. But most patients pay out of their pocket. They never get the genetic testing done. But we do know that they have that. And for example, in southern parts of India, where a lot of consanguinity is known, the atypical or late onset Canavan disease. I've seen a village where I practiced had more than 20 families with late onset Canavan disease, which is very unusual to have. So still there are many clusters, and I think it's going to be all over the world. It's just being under-recognized and not having much access to a genetic confirmation at this time.
Okay, those are great points. I need to open the chat to go back to the question. Dr. Gupta has joined us from California, so thank you. Maybe I'll take the next question to you, if that's okay.
Sure.
A major aspect is the day-to-day nursing care of patients as their disease progresses. For example, bed sores develop, which often become chronic. Other conditions related to the debilitated state of the patients also present huge challenges, such as difficulty in swallowing, choking, tripping, falling. Is attention to this important quality of life part of this project? So if you want to comment on that, that'll be great. Thank you.
No, absolutely. I apologize for my delay. 100%. And I think those are, those highlight kind of more the end stage even. And I think even earlier than that, just highlighting the importance of always thinking about kind of the patient's experience holistically, and always going through that kind of review every time, a patient is seen, or if you are a physician seeing a patient, just the importance of reviewing all of that, because you want to catch all of these things early so you can intervene. When I joined, I know they were talking about bowel and bladder issues, but anything you can do before it gets to the point of having, needing more manual kind of maneuvers or even surgical procedures and things like that. Obviously these things can start, especially in the natural history or the course of the disease, they can start much earlier with more kind of nuanced changes that then can obviously progress into, kind of more and more difficulty. So I think recognizing that and creating kind of an interdisciplinary team, whether it includes physical therapy, occupational therapy, home health, speech therapy for the swallowing and other things is really just important as you kind of work through care and kind of progression that may be resulting in patients.
Thank you. Did either of you want to add to that? No.
Well, specifically to bed sores, definitely this is not only a source of discomfort for the patient, but for the family also, and how to care for that. And that would be typically a dermatology, between dermatology and probably now people on home care are supplied by specific beds to prevent bed sores. And also these beds can have a specific mechanism to move the patient, to reposition the patient. So definitely these are available and are very important for the patient care, but also for the caregivers as well.
Thank you. I'm going to read a few comments here. So Dr. Roswell Aldridge, we all talked about that paper, is still alive and lives on a large abandoned farm in New York. I would like to direct him the recorded version of the ADLD symposium. Please do, I guess, and thank you for letting us know. Did you know that? No, I don't know if our audience knew that, but I guess thank you. And then how can one share these guidelines with specialists a patient might be consulting locally? You know, we're hoping to get this out soon. We've been persistent. We've revised them a couple times. I think the larger journals may not be that interested, so we might be just sending it to Journal of Rare Disorders soon, but we want to try the high impact journals first and exhaust those options. So hopefully they'll be out this year. That's my goal. If not, then a summary of the symposium will definitely be out, and we will put that in that summary. So in one form or the other, end of 2024, you will see it, is all I can say. Moving on, somebody commented that Dr. Appleberry already alluded to this, but as a panel as a whole, especially clinicians, would you be willing to collaborate with specialists treating patients wherever they might be? Travel is difficult logistically, if not impossible. So I think I'll let other answers, but I would say yes, absolutely. We all do kind of video visits often or provide video consultation. I think she said that the first time they come, it might be best to have one inpatient visit just based on rules at your institution, and then follow-up can be virtual. But all of us as clinicians are invested in ADLD, and we would love to help patients as best as we can. Just the other day, I had an email from a patient asking for a physician in California because they couldn't travel. And I gave Dr. Gupta's email or address, and hopefully the patient contacted her, and she's nodding, so hopefully she did. So I guess that's the whole point of this group, that we know our names and faces, and we're kind of spread out over the country. And so in one or the other state, we'll hopefully get to somebody who understands ADLD. Would you like to add to that, Dr. Tobin? No, agree. Okay, moving on. Is pelvic floor and biofeedback therapy useful for urologic issues and constipation? Who wants to take that? Yeah.
I think the question earlier on was specifically about bladder urgency. So obviously there's other causes for bladder dysfunction other than neurogenic bladder in the context of ADLD. So you can have pelvic floor dysfunction as well. So if that's the case, then pelvic floor exercises and biofeedback can be helpful. I guess that it just highlights the fact that the patients really need to see a urologist and have an appropriate examination to determine what the cause of the bladder dysfunction is.
Thank you. So this last question, with genetic whole genome sequencing, is it common to also see autosomal dominant spastic paraplegia? It's listed as a symptom of ADLD and also its own pathogenic issue. So not sure if I understand this correctly, but ADLD and autosomal dominant HSP are two different genetic disorders, and whole genome sequencing can pick up hopefully both of them, but they're genetically different. Clinically, they may look similar for a bit, but they're genetically different. So hopefully that answers that. Anything else? Yeah, okay. Last question thus far, is collecting of speech samples useful for monitoring as per the talk earlier today? So I'll let Dr. Tobin answer that.
I think it's probably unlikely to be specifically helpful for ADLD. I was just highlighting it as to point out that for if a patient has a particular deficit, that's the thing to follow. There's no point in following something that they don't have. For patients with histiocytic neoplasms, they very commonly have progressive dysarthria. And you know that it may be useful in something like Canavan's disease, but for ADLD, I don't think we see that much, at least early in the disease. So it's probably not going to be a useful marker for a natural history study early.
Thank you. I think, well, maybe more is coming. As a non-neurologist, recently retired physician who's focused on CF care and CF Foundation Therapeutic Development Network, and with a close friend affected with ADLD, this has been an outstanding seminar spanning all the key topics. Thank you very much for your comment, and thank you, everybody. Or to close on, exactly. So, okay, so thank you all. I'm looking at her, am I closing? So I guess we're closing this session. So thank you everybody who's present online for the lively Q&A and the chat, and all the speakers who were able to join online, and others who couldn't come in person who wanted to be here in person. Thank you nevertheless, and thank you for everybody who's in this room. So again, a day full of learning. I learned a lot, and I bet everybody in the audience has as well. And think we all are energized with new ideas, and hopefully new and great and better research is going to come out of this. Looking forward to future symposium on this disorder, where we'll have hopefully data from a natural history study. We're close to starting it, and hopefully we'll have more data to share. So now we have our reception, followed by, reception at the Kellen building. Dr. Roddy, thank you. Yeah.
Thank you all.
Yeah.
It was a pleasure to see all of you.
Thank you very much.